Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Binod Dhakal, a leading authority in multiple myeloma at Medical College of Wisconsin. He's been involved with some of the latest developments in multiple myeloma, and we have him today to discuss with us an abstract that was presented at the American Society Hematology meeting in 2024, which is a phase 3 trial of daratumumab with lenalidomide versus lenalidomide and dexamethasone in frail patients with newly diagnosed myeloma. Welcome, Binod.
Thank you, Ravi. It's very nice to be here and then talk about the study.
So, so could you, for our audience, just give them an idea of what the study was, and then obviously we'll delve into the demographics and the results.
Definitely. So this is a very interesting and very important study for the clinical practice, I would say. It's a phase 3 study comparing daratumumab with lenalidomide and comparing that to lenalidomide and dexamethasone backbone. Mainly focusing on patients who are more than 65 years of age and who are frail patients. So they looked at the frailty assessment, and those patients who are more than equals to, frailty, they were included in the study. So, and the reason why this is important is because in our clinical practice, when you look at purely transplant ineligible patients, I think frailty is a very important consideration that you have to take into account, independent of the age. So having that in addition to the age really helps us to have to inform practice on the significance of this regimen in this patient population. And just to to give a background context, the daratumumab with lenalidomide dexamethasone is already approved regimen based on the Maya trial, and which is a very, very effective regimen. At the 5-year, the PFS is more than 55%, and the median overall survival is almost 90 months. That really set the kind of a very strong background or the platform for these patients. But they included patients with all type of frailty status. So I think the question that comes up is how this regimen do in patients who are frail. Do we need to, like, if DARA is going to be safe treatment, combining DARA and lenalidomide is good, or what is the role of DEX and all those? That is not really known. So I think this really tries to answer that question in a phase 3 randomized fashion. And I think the beauty of this is it avoids the dexamethasone in the DRD backbone. And that has been the approved regimen, and here it completely avoids the dexamethasone. We all know that dexamethasone is not a great drug, especially for elderly patients. By default, we decrease the dose of the dexamethasone to 20 milligram weekly in older patients over age 70 in our clinic. But somehow, like in the prospective trial, this has not been investigated. How would it behave if you completely have the steroid-free regimen with these newer drugs? And this is what it looks like. And the primary endpoint given the phase 3 is progression-free survival, but they looked at the number of secondary endpoints as well as MRD negativity. So I would say the design is very clean, and the patient population they included was pretty relevant to the practice that we do in our day-to-day setting.
What was the demographics of the population enrolled?
So if you look at the median age is about 81. I think that again tells you how really the transplant ineligible. When you say about the transplant ineligible patient, everybody has a different cutoff of when we offer transplant to the patients or not. I mean, for us, somebody like us, which is a very transplant heavy program, we have been doing transplant for patients up to 75, 77, 78, as long as they're very healthy and their performance status is good. But here, I think, the patient population is much older. The median is 81. So even for patients who are, if you ask me, like, what is the upper age limit I will do transplant I have done in patients over 75, 78, but not up to 80-year-old and higher patients. So I think that speaks of how sick and how old this patient population is. And so the median age is quite remarkable to see that patient population being represented in the study. And in terms of other, the frailty status, I think that is something that, we may or may not do objectively in the clinic, but that is something definitely guides us in choosing the regimen. And here you can see the patients who are more than equals to were exclusively included. That means patients who are maybe not completely fit enough to go for transplant, that you would otherwise, not do a transplant, do a non-transplant based treatment were included. And patients who have frailty of 5 is almost 8-10% of patients who are with frailty of 5. So that means really, kind of a weak patient population, a frail patient population. In terms of other disease characteristics, I think, is pretty much comparable. There's nothing out of ordinary in terms of high risk. There is about 16-20% of patients are high risk, which is expected as well. I think the creatinine clearance is something that you can look into, especially when you're using lenalidomide-based treatment. You look at the kidney function in here, the patients with 30 to 60 kidney, the CG, the creatinine clearance is also like half the patients who were into that group. So again, saying that, looking at overall kind of frail with this comorbid patient population.
So what were the top line results?
Yeah, I mean, the primary endpoint is progression-free survival. You can clearly see how significant benefit that the CD38-based regimen would provide in the frontline setting. The primary endpoint was met, and with the hazard ratio of 0.51, the median progression-free survival at about a 46-month follow-up was 53.4 months in the Dara R or daralenalidomide arm, and it was significantly higher compared to lenalidomide and dexamethasone arm, which was 22.5 months, and with a hazard ratio of 0.51. So that is quite significant. Not only that, and if you look at the overall survival, that is quite significant as well, with a 4-year overall survival of 68% in the Dara-Len arm versus lenalidomide and dexamethasone in about 48% with the p-value of 0.52, and that is quite significant as well. And the follow-up is quite long, I would say almost 4-year follow-up. So both PFS and OS are significantly higher, and that is one part. And in terms of response rate, you can see the overall response rate 94% in the Dara-Len arm, and that was also higher compared to 86%. But what is important to see the deep responses, the VGPR and better, it was 71%, and that is probably driving this PFS benefit. And you can see the deepening of the response as you go with the time. As you see, the month 12, the rates of VGPR and better is much higher, compared to the earlier months in the Dara-Len arm. So that means adding this daratumumab will continue to deepen the response, not only driving the deep response at some point of time. I would like to see the MRD negativity, but I don't think we have the data yet in this presentation. But clearly, this is clearly probably drive the higher MRD negativity responses with the Dara-Len arm as well, and that's probably is driving the deep responses and PFS.
And what about subset analysis?
So I think this is a very important slide, in my opinion. If you look at this, and one of the questions that comes up, especially with this regimen, is how it's going to do with the much older, much frailer patient and with the multiple comorbidities. And here you can clearly see that, patients who are 80 and older, patients with the performance status, or the comorbidity index much higher, and the frailty score, higher frailty score, you can clearly see in the subset analysis that Dara-Len consistently provided benefit compared to the Lendex in all these three groups. So that is quite interesting and important observation, because we see in the clinic much older patients, probably 90s and 80s, and were frail, and you think twice, are these patients going to benefit with the daratumumab with the lenalidomide combination, or they are going to be better off with just one drug, what is the role of steroid in that, how quickly we can avoid the steroids so that we don't lose the benefit. And here you're clearly seeing that having the daratumumab lenalidomide without steroids, you are benefiting all these subgroup of patients.
And anything to further add on the subgroup analysis?
No, I think that is, again, as I said, all subgroups did benefit, including the poor risk subgroups where you think twice before starting any regimen. And I think this study gives very good confidence for us clinicians to use this regimen in much older, much frailer patient, and they will do so that they can derive the good benefit for the outcomes.
And how was this regimen tolerated?
One of the things that comes up is how safe this drug combination is, any drug combination for that age group. If you look at the side effects, at least the grade 3 and 4 adverse event that is reported in the study, I would say that is also quite expected. I mean, one of the major concerns when we use this regimen is the cytopenia. And you can see the grade 3 cytopenia was listed here, especially the hematological toxicities. But if you look at the lenalidomide dexamethasone arm, there is not much of huge differences in terms of that. I think what I would focus on is grade 5 AEs. When you look at the grade 5 AEs, it's pretty comparable, 12% versus 13%. And that again tells you that this is a sick patient population, a frail patient likely to have these other comorbidities, but having these two combinations, daratumumab and lenalidomide, doesn't add up much than what Lendex by itself has done. Infection is another concern that we look into it, but grade 3 and 4 infection actually is pretty comparable in both the groups. And lastly is the treatment discontinuation rate, because most of the time when we start these patients, this group of patients on 3-drug regimen, they won't be able to handle it. So you have to drop down one of these medications or completely drop down all of this treatment if there is too much of side effect. But here it is interesting to see that the discontinuation rate in both the arms are similar. So that means having Dara and Len combination didn't add on too much in the discontinuation. So overall, I would say that I was expecting the negative side effect of steroid, and then with this steroid sparing kind of the effect with this Dara-Len, I was hoping to have a little bit better maybe side effect profile with the Dara-Len arm and then the Lendex arm. But at the same time, it is also very encouraging to see that there is no new or no increase in the rates of this adverse events that is listed here.
And what about how did the patients feel?
I think based on the two quality of life metrics, observation that was used in the study, EORTC QLQ-C30, which is the most commonly used one, and the EQSD3L, I think you can clearly see that having patient on Dara-Len is probably improved the quality of life, and that remained stable. And partly because of multiple reasons. One, you are avoiding the steroids, and number two, Daratumumab goes once a month, after a certain time. And so that doesn't have a lot of impact on having them to come to get the injection quite frequently. And more importantly, the disease remains under better control. So all these things probably could have contributed to the improved quality of life, because somebody with having like a higher disease burden impacting the quality of life in that age group, we're decreasing the burden very effectively and maintaining that lower disease burden for a longer time, and that's probably impacted the quality of life.
So what's the key takeaway from the study?
So I think the key takeaway is that we know that a Daratumumab, Lenalidomide, Dexamethasone is a very effective regimen, is an FDA-approved regimen with a median overall survival of almost 90 months in transplant-ineligible patients. When you look at the transplant-eligible, ineligible study, I think Maya was probably a purely transplant-ineligible study. Having said that, the transplant eligibility is again very subjective, and we have been using transplant-based approach in much older patient, than what is studied in Maya. I think one of the key questions that was again not exclusively studied in Maya was frail patient with frailty score of more than or equals 2. And I think this study is a kind of really provides that significant evidence, exclusively looking at older patients with the frailty status more than or equals 2, and showing that Daratumumab with lenalidomide without the addition of a steroid provides significantly better benefit compared to RD backbone that was studied for both Maya as well as in this study, and improves not only the response rate, but also the both progression-free survival and overall survival outcomes. And we know that Maya also had a survival benefit compared to RD backbone. So it's very important. That tells you what the significance of CD38 based regimen in the frontline setting. And number two, in terms of safety profile, favorable safety profile, without increased risk of discontinuation, as well as the increased risk of infections. So I think this again, some of us are already doing the practice, avoiding the steroids after certain doses, but this study kind of just supports that. But more importantly, supports that, especially when you're looking at the frail patients, the significance of these two drugs together without adding too much of, adverse events.
So obviously there are a number of studies now looking at 3-drug regimens, VRD, Dara-RD, 4-drug regimens, Dara-VRD, Isatuximab VRD, and now we are going back to a 2-drug regimen here. So how do you, in your own practice, decide who's going to get 2 drugs, who's going to get 3, who's going to get 4?
No, I think that's a great question. I mean, the honest answer is we really don't know. But if you ask me, when you look at those studies, so for example, for the 4-drug, we have 3 studies in transplant-ineligible / transplant-deferred patient population, IMROSE, CEPHEUS, and BENEFIT. And for purely transplant-ineligible, we have 2 studies, including this one. I would say, purely transplant-ineligible, we have 2 studies, this one and the Maya one. So my practice, if you ask me, is for patients who are over age 75 to 80 or more than 80, DRD, is the backbone of regimen of the triplet. But as I said before, dexamethasone, you kind of very quickly kind of get rid of the dexamethasone very quickly. So we are in general already doing this DR-based regimen in those patient population. So this study just adds or confirms the benefit of that regimen in this patient population. For patients who are 70 to 75 or less than 80 patient, where you are not sure whether this patient could be transplant eligible or not, I would say quadruplet is probably way to go at least to start off, based on the again CFIUS and IMROSE and benefit study. Then deciding whether this patient really gonna go to transplant. Now, when I say transplant, now the things have been changing a little bit because with this highly effective regimen, the question of transplant is debated, and especially if you are not able to offer 200 milligram per square meter of melphalan dosing in this patient, then again the data suggests that you are not really good, giving the good benefit on the outcomes. So if you cannot do that, probably quadruplet is equally, probably quadruplet is a very effective option. The question we won't know it how these patients would do when they get quadruplet followed by MEL 140 or MEL 200. So we don't know that answer, right? So the practice-wise, this study kind of just confirms what we have already been doing, and I think it's very interesting and very important to see that doing this steroid-free regimen, which is what most of the studies are looking into right now, and showing the significance of how these newer drugs like CD13 monoclonal antibody and its role in the frontline setting of the multiple myeloma. And it just tells you that even frail patients, which are more than 2/3 of the patients, they're diagnosed over age 70. A lot of patients can be frail, and then even despite that, these patients can derive anti-myeloma benefit with this regimen.
Well, Binod, I really thank you very much for taking the time out of your busy schedule to talk to the audience about this new study. I hope I can turn to you as we have more things to discuss in the future.
No, thank you. This is a very important study. And as I said, it is very clinically relevant in our practice.
Thank you.